Thank you very much. Ulrich, am I audible?
Yes, perfectly so.
Thank you. Greetings from Bangladesh. I would like to provide thanks to the organizers of the Interdisciplinary Summer School on Snakebite Envenoming 2023 for kindly giving me an opportunity to listen to very important communications for the last 5 days. And we have listened right now, Professor John Amershi, who has kindly gone through in a very excellent way the various aspects of the strategy for prevention and control of snakebite envenoming. And the deliberations for the last 5 days, it gave me an opportunity to flashback, and I find it quite important that how we are lagging behind in terms of translation of whatever we achieved in terms of the policy related to public health policy related to snakebite envenoming. If I recollect, the pre-antivenom era during the British period in 1870s, Sir Joseph Fair was the Surgeon General in India. At that time, they had a program. That program was for snake bite mitigation. And that program was by killing, that is snake killing program. They costed snake hunters, snake killers, and one of the responsibility of the district magistrate was to distribute money. At that time, the death in Bengal means present Bangladesh and the current West Bengal of India, the death was around 7,000. And there were more than 1,200 cattle died at that time. So this is a very old topic before development of even antivenom. Now, coming to the topic, I think we all agree that it's a real time-critical acute emergency in tropical countries, causing an unacceptable number of deaths and disability following bite. This is a reality. At the same time, there is an inadequate policy related to snakebite envenomation, considering the enormous public health importance. I think the regulations, the laws, the government circulars, these are quite insufficient in comparison to burden. I am not going to talk at all about the detailed aspects of the strategy, the global. We are fortunate that in our region of Southeast Asia region of the World Health Organization, we have the regional action plan from 2022 to 2030 based on the global snakebite strategy. And I like to focus on very few aspects of the problem. About the data quality on disease burden for any disease, including its incidence, morbidity, mortality, and severity, is crucially important. I think by taking snake bite, I think as an illness, this can be an example for the nation as well as within the country. The few countries of the snakebite affected low middle income countries have regular snakebite data from the community and hospitals. There's huge discrepancy as we listen to the communications in few days, that the discrepancy is huge between the community and the hospital data. The recording of cases of snakebite in health facilities, ideally, this should be nationwide, but initially we can identify some sites. Of course, the periodic national survey can be done. We have the information across the countries that non-venomous bites outnumber the venomous bites. Of course, it is very difficult to distinguish in the beginning. So I think in this particular area, the policy should be that there should be a mandatory notification of the snakebite cases. This can be considered. I think it is the countries they have to implement the WHO strategy. They have committed it in the in the global forum in the World Health Assembly. So this can be an important policy for mandatory notification. In our region, this is the most vulnerable in terms of the total number. More than 50,000 deaths in India, quite unacceptable. 7,500 deaths per year in recent data from Bangladesh. Now, from long before, there are some small-scale studies which gave hints that there are more than 20% patients of snakebite used to die in 1995-96. In a relatively new data from early part of the century from Bangladesh, there are 600,000 deaths has been recorded in around 700,000 cases, 6,000 deaths per year. In this point, at this time, I'd like to mention that we are fortunate to have the latest survey in 2022, which estimated around 244 per 100,000 cases, which less than 25% are venomous. And estimated bites around 400,000. Male is more than female, and estimated death is more than 7,000, nearly 7,500 due to snake bite, mostly in the rural areas, highest during the young age groups. For the first time, we could record in an objective fashion in the follow-up cases as well as during the survey, around more than 10%, 10.6% reported mild to moderate form of physical disability, with around 2% post-traumatic stress disorder. To mention here, in Bangladesh, in the community, the disability rate is less than 3%, something like 2.8%. This is rightly mentioned by our colleagues that this is the One Health issue. We estimated 2,500 domestic animal cows die due to snake bite in Bangladesh. So besides the human, the animal data, the snake bite data from Venom Research Center in collaboration with Forest and Environment Department and Rescue Team, there are samples from different places. We could detect newer local important species identified in Bangladesh like greater black rate, Vangaras wali, lesser black rate, and the emergence of Russell's viper from at least from 18 out of 64 districts. The collected snakes given very important findings here. If we see that if we distribute the species throughout the country, I like to talk about the Naya snake. The Naya coyotea is available across the country, here mentioned in red. Whereas the Naya, it is present on the western part. The antivenom that we are using is raised against Naya in the polyvalent. So the next important point is health system. The national health systems and efforts to face this snake bite should be strengthened. This is a cross-cutting approach, of course. The nature of health system in many countries, including Bangladesh, is complex. Public and private mix. Unfortunately, most of the cases in the private sector, they do not treat snake bite, mostly treated by public hospitals. The status of universal health coverage, out-of-pocket expenditure is very high. The challenge is equal access to services to high-burden remote areas. The policy should be, I think this is not an aspiration, to provide free treatment by antivenom and other logistics for the victims of snake bite. By strengthening the health system, you can test that your health system is reciprocally responding to achieve the sustainable development goal. So snake bite may be a litmus test for the health system. So there is possibly in few countries there is dedicated snake bite national control program on snake bite, except maybe one or two exceptions. In the last year, Bangladesh developed the National Snakebite Strategy and Cost Action Plan based on the WHO and regional strategy. This is in the process of approval. We expect to have this approval very soon. I'm not going to talk details about this strategy. We listened since for the last few days that there are enormous problems in terms of treatment-seeking behavior of the community following snake bite. Dominant dependence on traditional healers. There are different views of community engagement, but there are opinions that these are maltreatment. I think there might be some debate for policy decision related to continuation of these maltreatments prevalent in the society. I'm not going to talk about what are the varieties and how they are being mitigated. One of the important component of a health system would be emergency healthcare system, starting from scene to transport to arrival in the hospital and providing necessary support. So for snake bite, I think this is a very important point to note that emergency and transport system in many countries, including Bangladesh, many persons used to die en route to hospital because of the absence of failed resuscitation. In this case, during a short period of 36 months, there are only 6 deaths in a hospital. Unfortunately, at the same time, 27 patients deceased, they are brought to hospital. So effective pre-hospital care and rapid transport with referral to system capacity strengthening, I think this would be an important policy for public health, because by treating snake bite as an emergency, the other aspects of the healthcare delivery, this same expertise can be utilized for addressing other emergencies as well. As I mentioned, the specific treatment for antivenom raised against the major force snakes of India was first developed more than 130 years before. In 1967 in Costa Rica, in early attempts for production of antivenom in Bangladesh, it was not successful. Sri Lanka, it was also not successful, but they're not trying to develop it, as we listen to the presentation from the World Health Organization. So the availability of the antivenom and other logistics and drugs in the healthcare, according to the policy metrics, as for the terms of reference in different facilities, this should be available in terms of the antivenom being an essential drug. The countries who do not produce antivenom, Bangladesh is one of them, is always in short supply. There is huge problem in terms of procurement, in terms of supply, distribution, storage, more so if it is serum form, and availability of antivenom at the time of use. There are also problems related to availability of antivenom, but as the patients are not coming to hospital due to treatment-seeking behavior, sometimes the procured antivenoms, date of procured antivenoms expires. The WHO recommendation to produce country-specific antivenom, I think this needs to be a policy decision. This is not practiced in many countries in Bangladesh. Of course, capacity is an issue. We are trying to improve the capacity. There are other cost-benefit concerns as well. At the same time, whatever antivenom we are procuring or we are going to produce, the regulatory capacity, especially on the quality control of antivenom, to ensure efficacy and safety is very essential policy to be addressed. For example, even if we do not produce antivenom, but we have to test the efficacy of the used antivenom against the commonly prevalent snake. So we need the precious materials from our own snake as an essential necessity. There are other issues about polyvalent and monovalent antivenom. I'm not going to talk details about any of those aspects. As we listened yesterday, the antivenom that we are using raised against Indian big four, Bangaras caroleus, Naya, Achis carinatus, and W. raceli. but the Bangladesh species, the highest mortality are due to monocle cobra, greater black rate, Wall's rate. So these are not included in the Indian polyvalent antivenom production. So access to new antivenom, if we can develop that specifically for Bangladesh, would bring many benefits. As we see here, the Brussels viper venom from Bangladesh is quite different than against the Brussels viper venom from South India, which is being used for the production of antivenom. And our colleagues in Bangladesh found that the mortality due to following Brussels viper is quite high, particularly even despite they use 10 vials, sometimes 20 vials of antivenom in addition to providing other supportive treatment. Now, coming to the healthcare, in terms of healthcare, the training of the human resources in managing snakebite. There are WHO guidelines, regional guidelines, and country-specific guidelines related to training, providing training to the medical doctors, nurses, and healthcare workers. There are the medical curriculum in many LMIC. They are not able to develop the competency among the healthcare professionals in managing snakebite. Possibly this is not adequate. For that, we need to have a policy related to competency-based training, which is a continuous training with supportive supervision with hub and spoke model. We are now currently trying this in couple of places, in few places, connecting small hospitals with nearest bigger hospital 24/7 by WhatsApp group as well as by other communication. In this point, I like to mention that preparation of a digital tools and methods for permanent education program and in-service training should be a policy. This should cover the antivenom usage, tackling reaction, pharmacovigilance, competency of assisted respiration dialysis. When we are listening in this morning about the new therapeutics, whenever there are new options comes with the gold standard, now the gold standard is antivenom. Then every time the people will blame the antivenom. They will say that the antivenom cause lots of reactions, lots of side effects. But in our experience, we use Indian polyvalent. We know that there are lots of side effects, but with proper pre-medication and appropriate use, I have not seen my colleagues. They have not found a single case of death due to antivenom reaction causing anaphylaxis and which cannot be avoided. I think I would request our colleagues who are developing new formulations, please try to realize that our colleagues in LMIC, they are very afraid of using antivenom. But if in the beginning, if you start like this, that antivenom cause lots of reactions, there will be further hindrance for promoting antivenom, which is still now, this is the gold standard. We need to do many things in terms of improvement. In the training, this of course, the provision of respiratory support, provision of management of AKI will be crucially important in countries where there is neurotoxic and vasculotoxic, hemotoxic snakebite are there. And one of the important components should be provision of respiratory support. I would like to mention here the production of antivenom is older than respiratory support, provision of respiratory support. Previously there was only negative pressure ventilation with iron lung. There were survivors up to 70 years, only 2 weeks before there was a report like that. And only in 1952 in Copenhagen, there was polio outbreak, which was, there was resuscitation by using positive pressure ventilation, by using ambuboic, and resuscitation by students, nurses, and medical students, nurses, and other paramedical students, 1,500, causing reduction of mortality from 87% to 41%. So I think in all the LMIC where there are limited capacities, this bulk pass ventilation should be standard of care in small hospitals. By mere using antivenom, possibly it will not be possible to revert neurotoxic snake bite. In this case, the 10 cases they were reverted by using only simple ambu bag and using providing respiratory support. At that time, maybe 20 years before, there was no assisted respiratory support. Even if it is available in various categories of hospitals, unfortunately, in many times, the bed occupancy rate in ICU is 200, 300%. So there is no bed available for providing respiratory support to the unfortunate victims who are poor victims of the community. I think this should be one of the policy for the LMIC to have this mandatory training to include this advanced life support. The presentation by Dr. From our colleague from Nepal, Dr. Isabella, was excellent. The community engagement for providing appropriate first aid, quick transport to hospital, and prevention of snakebite, this should be an important policy for all LMIC. It should be adopted by country-specific, culturally appropriate interventions, and this should be implemented. Investment in communication materials and communications, including digital communication tools and materials on IECs. Community engagement is the key. Multisectoral involvement will be needed, and behavioral change of the community is a challenge. Now we are doing some experiment in the community interventions by a package of interventions providing by various means, and then comparing with the baseline after 1 year. We are going to assess it after 1 year, after 2 years, so that we can replicate the same things across the country. So this is a community trial that we are taking, and also from India and other parts of the various countries, including Nepal, they are doing this for having behavioral change. The principles of sustainable development goals include universal health coverage, reduction of out-of-pocket expenditure, and poverty alleviation. I think I do not find any better subject than snakebite to test our capability of achieving sustainable development goal. The provision of snakebite prevention, first aid and management close to communities at sub-district level will directly contribute to achieving SDGs, as snakebite mainly affects marginalized rural people and farming communities and their livestock. The various materials shown by our different colleagues from across the country, it includes the immediate first aid, what not to do, and how to prevent it, with simple identification of the venomous snakes prevailing in the country. There are various types of materials developed. There are including leaflets and other social media, community education, entertainment through entertainment, so and so. So as I mentioned, a parallel road to snakebite prevention and control should be equivalent to achievement of sustainable development goal in many LMICs. It includes not only 3.8, in addition to poverty alleviation, as well as rural housing, which is very vulnerable for the trade bite at night time, as well as the improved housing in the 11.1, the improving electricity and lighting as SDG 7, outdoor defecation elimination as SDG 6.2. All are linked with problems of snakebite envenoming and other health-related issues. Thus, we think that the community engagement and health system strengthening activities of snakebite mitigation will also contribute to achieving targets corresponding to these SDGs. There are many topics to be covered for mitigation, for management, for prevention of snakebite. So there should be a dedicated group to have what are the research topics that should be to be covered. For doing research, they are having skilled human resource in endemic countries. We think that in every country there should be some setting where other studies can be done, as well as the snakebite studies can be incorporated. Particularly, we are very pleased to see that there are point of diagnostics are being developed. Newer therapeutics are on the pipeline. Of course, there should be more work to be done on the clinical trials, adhering to good clinical practice. So development of clinical trial sites should be one of the important policy for LMIC. And implementation of these various BCC interventions impact, as we listened, that people are asking whether these interventions are working or not. So these are the very important immediate research that is done. Particularly, every country there should have venom research center to have the gold standard of their venom, for not only for developing anti-venom, but also for preclinical and neutralization assay, because this is one of the mandatory things that we should done by every country using the venom standard and assessment of neutralizing capacity of currently used antivenoms. We are very fortunate that we have the Venom Research Center in Bangladesh, which is using, I think our colleagues gave 2-3 presentations from that. The capacity development in this particular field on omics science is very essential. Particularly, we think that there is currently, we are talking about acute management of snakebite, but there are lots of disabilities, as we have seen. So disability assessment and mitigation should be one of the important priority, besides promoting interdisciplinary research. These are some of the very disabling conditions that are having fallen snake bite, either directly or indirectly by the various interventions. So this needs special attention by assessing, by having follow-up clinic, by structured format, which is yet to be developed in many countries, including Bangladesh. In conclusion, I would like to say that the key public health policy relevant for snakebite envenoming should be driven by having development of country-specific snakebite strategy, conforming with WHO strategy, which includes at least some of the very important components, as we have discussed over the last 5 days, particularly engaging the community for providing appropriate first aid, quick transport to hospital, and prevention of snake bite. The mandated notification of snake bite should be considered. At the same time, maybe snake data also should be collected. Competency-based training, there is no option but to have the competency-based training, which will not only provide enough confidence for managing snake bite, but also can be replicated, can be utilized for managing other community emergencies prevalent in the countries. There should not be any compromise about the availability of antivenom. This is a right-based issue, and including other logistics and drugs. So we should have a firm policy that the antivenom should be available in as far as possible in small hospitals close to their community, which will provide very drastic reduction of death, as we have seen from Nepal. To provide free treatment by antivenom and others for the victim of snake bite. As we are aspiring, we are talking about sustainable development goal. In the last week, we again reaffirmed our commitment for sustainable development goal. So this is the time to test our capability. Of course, the countries should try to produce their own country-specific antivenom. At the same time, the regulatory capacity, especially on quality control of antivenom, should be one of the agenda items. With this, I would like to provide enormous thanks for kind attention and giving me an opportunity to have interaction. Thank you very much indeed.